participants. Okay, good. All right. So I'm going to go ahead and just jump right in. I know you've got Dr. Lynn's, he does a fantastic job with his aortic lectures. About myself, I'm Sundip Maru. I am a vascular surgeon out of Western Massachusetts. I have been practicing for nearly, I want to say 17 years now, coming up this summer, 17 years, which is kind of crazy. Um, and I always joke that out of all my jobs, Osler has been the longest one I've been with. I've been working with Osler for nearly 14 or 15 years now, in some shape or form. And it's because it's something that I'm passionate about. I believe that these exams are just another hurdle, and I think we all are here just to try to help you guys out to try to get through these. So, um, I have several lectures coming up. I rearranged the schedule just a little bit, and I think Michael updated that schedule. So it will look something like this. Today, I'm going to talk about dialysis access, vascular complications, and the vascular lab. And that'll take us, and I'm going to probably plow right through, and that'll take us to about 6 o'clock. Tomorrow, I will be covering venous DVT, which will be one of my longest lectures, lymphedema and non-atherosclerotic diseases, which will take about 2 hours to get through as well. So you'll have me again tomorrow morning. Um, and so through these lectures, I'm going to try to give you the most updated information. Um, I think that the biggest change, and I was looking at my old slide decks, the biggest change has been in the venous world. It has been like the great space race of everything changing. But either way, we're going to jump into dialysis access. So I work at a Holyoke Medical Center right here in Western Massachusetts. It's a small community hospital. We are a teaching hospital for Quinnipiac out of Connecticut. And my standard disclosures and dialysis access. So we're going to jump right in, and we'll start talking about that. If you can, if there's people out there, you can just drop answers right into the chat function up there. And as we go through questions and towards the end, if there are any questions, please feel free to ask. Because if I didn't cover it, I bet you somebody else is thinking the same question you are. So, first question. Patient with progressive CKD has opted for hemodialysis for RRT. What type of vascular access is associated with better outcomes in hemodialysis patients, right? So a central venous cuffed catheter, AV graft, AV fistula, or a temporary central venous catheter. What do we got? Anybody? Jets? Anybody? All right. So a couple of answers out there. And so we're looking at AV fistula. Fistula first, right? So that's going to be always our answer, right? Native fistula. Whenever there's a question, always think of fistula. All right. We'll get into more details about that. All right. Question 2. Another patient with CKD is considering a kidney transplant. Which of the following statements is correct? CKD is a patient can be referred to a transplant center when their GFR is less than 20. Preemptive and live kidney transplants are associated with better graft survival. Most common cause of kidney transplant loss is death with the functional transplant. D, all of the above. What do you guys think? A couple answers out there. And sure. So we're looking at D, right? All of the above. So all of these things are good. The one that's kind of shocking is kidney transplant loss is death with the functional transplant. So, and so let's get into it. let me start off with just a little brief history and then we'll get into that. So, early 1900s, it was first developed in 1943. First successful treatment is 1945. So it's only 80 years old that we've been doing this. Um, they started with Teflon tubing, first outpatient center in 62. So function of kidneys, right? You've got nephrons, glomeruli, waste tubules. And so it's a cleaning function along with hormone secretion to support homeostasis, sorry. Chronic kidney disease failure. One of the top causes, right? The top causes we deal with is hypertension, usually uncontrolled hypertension and diabetes. And then we're going to get into diagnosis, kidney failure, and then the function of dialysis, right? So, what is the indication of RT, right? Hyperkalemia, metabolic acidosis, fluid overload, the one that we see most often in the hospital, recurrent CHF, they're coming back, uremic pericardial rub, and then you got some of these non-specific symptoms. So anorexia and nausea, impaired nutritional, increased sleepiness, decreased energy level, attentiveness, and cognitive tasking. Okay. And so you have treatment options for RRT. And so we are here and you have end-stage renal disease. Ideally, you want to get to kidney transplant. There is dialysis. And like I said, transplant is your best treatment option. There's peritoneal dialysis. And then there is also, in a realistic setting, comfort care. When a patient comes in and you know that even dialysis is not an option, but they're in renal failure, right? So this is kind of just a generalized look at it. But when we look at dialysis, we're looking at two main things, right? There's hemodialysis. You're looking at in a center 3 times a week, or there is even home hemodialysis. And then you're looking at peritoneal dialysis, right? There's manual and cyclical. All of this can be done at home. The thing about peritoneal dialysis is that you've got to have a patient that is a little bit more compliant, a little bit more capable, has better